Hi guys. So tonight we're going to talk about endometriosis. But first, I just want to say thanks. Thanks for tuning in. This is a great way for us to connect with a bunch of you in a socially distant, safe way in the era of COVID. So we really appreciate getting an opportunity to chat a little more in depth about a topic. And as shall be mentioned, then of course, we would love to talk in more detail if you have further questions at the end of the presentation and of course in a consultation. So endometriosis is a common condition that affects many women in their reproductive years. It is a condition that can lead to pelvic pain or infertility or both. So tonight what we're going to do is we're going to talk about what is endometriosis, how do we diagnose it, and then how do we treat the pain and or infertility that is caused by the endometriosis. So first, in backing up, let's talk a little bit about what is endometriosis. And so every month when a woman has a menstrual period, what happens is the lining of the uterus here, it's lined by endometrial tissue. And this tissue will thicken and it will prepare for implantation. And if pregnancy does not occur, then the tissue will shed through the cervix. What happens in endometriosis is actually this endometrial tissue will grow in places outside of the uterus. So it may be on the top of the uterus, it may be on the fallopian tubes, it may be on the ovaries, maybe somewhere in the abdominal cavity, even the bowel or bladder. And growth of this tissue will lead to problems. So the endometrial tissue, the implants that occur outside of the uterine cavity will basically go through the same process that the menstrual tissue, that the endometrial lining normally does in the cycle. And this tissue will also thicken, it will break down, and it will bleed. But because it's trapped in the body, then it's going to lead to problems such as inflammation or scar tissue, which we'll talk about. So initially, often the endometrial implants in the abdominal cavity look like little flecks or blebs of tissue. They can be clear, white, brown, black, blue, but they do have sort of a characteristic appearance that we note, and I will show you later. These endometrial implants can become very large. If they do invade into the ovary, there's something called an endometrioma. This is also known as a chocolate cyst because the blood that is contained in an endometrioma becomes a deep reddish brown color. The endometrial implants can cause inflammation. They can also cause irritation of the pelvic organs, and also that will lead to scar tissue or fibrous tissue that actually binds the organs of the pelvis together. And so we'll talk about that, but these endometrial implants can lead to chronic pelvic pain. They can lead to scar tissue formation. They can lead to infertility. Actually, about 10% of women have endometriosis. Many women with endometriosis actually have no symptoms. About 25 to 35, some reports will say up to 50% of women with infertility may have endometriosis, and 20% of women with chronic pelvic pain. So as I said, many women with endometriosis actually don't have any symptoms, but when we're talking about the predominant symptoms with endometriosis, it's often severe menstrual cramping, also known as dysmenorrhea. Many women have cramps with their periods, but women who have endometriosis have very severe cramping. And this cramping actually can begin several days before their period, last several days after their period. Sometimes it is accompanied by low back or severe abdominal pain. It can be pain that radiates down both legs just due to the location of the endometriosis. This can be pain that just happens all the time, not even around the menstrual cycle. Many women also will experience pain either during or after sex or both. Endometriosis can lead to some abnormalities to bleeding patterns. It can lead to heavier periods. It can lead to irregular bleeding between periods. Sometimes the first time we figure out a woman has endometriosis is when she presents for a fertility evaluation. Also, women can have painful urination or defecation or passing a bowel movement. This is often something that's worse during the time of the menstrual period. And they may notice blood in their urine or stool as well. So these can be some symptoms that can correlate with endometriosis. It is important to note that the symptoms of endometriosis and the degree or number of implants actually don't correlate that well. So a woman might have severe symptoms, but actually have pretty mild or moderate endometriosis. And a woman who has very severe endometriosis, which may be discovered for other reasons, may not have many symptoms at all. So it's important to remember as we talk about the evaluation and treatment. So in terms of diagnosing endometriosis, one of the first important things about determining if endometriosis could be contributing to pain or infertility is understanding a little bit about the symptoms and asking questions regarding timing of the symptoms and the symptoms that we just discussed, the severity of those symptoms and anything that alleviates that pain, and just getting a better understanding of that. One of the first tests that we do is often a pelvic exam. So a pelvic exam is where your doctor is actually going to palpate the uterus, palpate to see if there is any cysts in the ovaries. Also with endometriosis, often the uterus may not move as much because it may be locked in with some of those adhesions or that scar tissue. Often the pelvic exam then is followed by an ultrasound. So a transvaginal ultrasound is often performed. A transducer is placed in the vagina, and high energy sound waves are used to display images of the internal organs. So the uterus, the ovaries. This here is an example of a grossly abnormal ultrasound demonstrating severe endometriosis. So here you see this is a peritoneal endometriosis, meaning that it's an implant of endometrial tissue on the abdominal cavity. And then here is the endometrioma that we talked about. So this is in the ovary. This is what we call those chocolate cysts. This, depending on the size, so it can range in size from a pea to a grapefruit. Depending on the size, it may be something that we consider removing, and we'll talk about that as well. But this is the first way that we diagnose it. This ultrasound actually also shows some vaginal endometriosis, which is a pretty uncommon finding, but when we see it on an ultrasound like that, it's pretty diagnostic that we will likely need to do some further evaluation. So the definitive way to diagnose endometriosis is actually with surgery. So the pelvic exam and the ultrasound and sometimes even MRI can be helpful for understanding that the likelihood of endometriosis, but however, the definitive diagnosis is with surgery. So surgery is often done with laparoscopy. So this is an outpatient procedure where there is a slender camera known as a laparoscope that's inserted at an incision near the patient's navel, and this allows us to see the pelvic organs. To show you the pictures here, this is actually the picture of a normal pelvis. And so this is the top of the uterus. I'm going to use my little uterine model here to kind of show you, but this is kind of the view that we're getting with that picture there. And then you can see, if you look at this picture, the fallopian tubes go down on either side. The ovary is here. And when you look at the wall, it's nice and shiny and clean. As opposed to here, you see some of those dark blue, blackish implants that we were talking about near the bladder. And this is several areas of endometriosis here. The benefit of the surgery is that it can diagnose endometriosis, but it can also treat it, and those implants can be removed. Now we talked about some of the inflammation, but here is when we were talking about the scar tissue or the binding of the pelvic organs together. This tends to be in more severe endometriosis, but this is the uterus and these are the ovaries. So you can see how drastically different they appear as compared to that normal pelvis. As you might imagine, and we'll talk about later, this can lead to some anatomical concerns with the egg getting from the ovary into the neighboring fallopian tube and making its way down the tube. The tissue is also sent to the pathologist. So during the procedure, these lesions can be removed. The scar tissue can be lysed or also cut back, and then the tissue can be sent to pathology to analyze for the official diagnosis of endometriosis. During the surgery, staging of endometriosis also occurs. So endometriosis is split up into 4 separate stages, kind of minimal, mild, moderate, and severe. Minimal is going to be a few of those superficial implants. So let's see, on our little uterus here, these little purple dots are a representative of mild, minimal endometriosis. So the staging is really based on the number, the location, the depths of those endometrial implants. It's also dependent on if there is involvement in the ovary, like an endometrioma, or if there's a lot of scar tissue. So the more severe disease is where we're going to have those adhesions or the scar tissue. Now, women with minimal to mild and moderate endometriosis may be able to conceive and carry a pregnancy to term without difficulty. Often, stage 4, though, will likely lead to some degree of fertility concerns. Okay, so let's talk a little bit more about how endometriosis is related to infertility. So as we said, one of the main complications of endometriosis is infertility. We do think that there's actually several mechanisms about how this happens. So as we talked about, there can be an inflammatory response. And we actually think in the mild to moderate endometriosis that the inflammatory response may be a big factor. It's pretty easy to see that with severe endometriosis and all the adhesions and the scar tissue, that it may actually make a physical barrier for the egg to be released from the ovary, come into the fallopian tube, make its way down the tube into the uterus to implant. But it's also presumed that endometriosis actually alters the uterine hormonal environment in subtle but important ways. And so there's some theories about inflammation, some theories about the immune system, some of the hormonal changes, maybe abnormal function of the fallopian tube, and definitely concerns with fertilization, implantation, and transport. So those are all areas under active investigation, but concerns where endometriosis could lead to infertility. As I said, many times women with mild up to moderate endometriosis can conceive without difficulty and carry a pregnancy to term. But obviously in those instances where that's not the case, we'll talk a little bit later about our initial approach to treatment and to fertility concerns. So just to talk briefly about how endometriosis is treated, typically the breakdown really depends on the predominant symptoms. So if the concern is pain, it really depends on the severity. So mild to moderate pain with someone not actively trying to conceive, first thing is going to be some oral medications, which we're going to talk about here in a minute. If the pain is more severe, then surgery is usually performed to confirm the diagnosis, but also to treat and remove the lesions and any scar tissue. Many times right after surgery, actually these oral medications are started to stop the endometriosis from recurring. If it does recur, then you can go a longer term medical treatment, often 6 to 9 months. If the pain does not get better at all and the woman is not interested in conceiving, then that is the time when we may consider doing a hysterectomy, potentially even oophorectomy, although that's falling out of favor. Oophorectomy is also removal of the ovaries. In general, though, when we see women who have infertility, we, many times will proceed with evaluation, and if endometriosis is suspected, there may be times when we will actually move forward into fertility treatments without doing a surgical procedure, and we'll talk about that a little bit later as well. The other option is that we do proceed with surgery, remove any of the endometriosis implants, any of the scar tissue, and then move into fertility treatment. And we'll talk about the specifics of those treatments. So this is going over some of the options for treatment for endometriosis pain. So actually the last one listed here is the non-steroidal anti-inflammatories, and this is going to be the first line agent. So this is going to help with the severe cramping during a menstrual period. This is your ibuprofen, Aleve, naproxen. Those medications can be very helpful in suppressing some of this inflammation and relieving a lot of that pain. So they work by a couple of factors there. But if a woman is not trying to get pregnant, we may add some supplemental hormones. So often the first line for those is going to be combination oral contraceptives or the birth control pill. These do a very good job of suppressing the degree of inflammation and menstrual shedding. And so that can be helpful for the menstrual shedding, that, the shedding of the endometrial tissue within the cavity as well. If a woman is not interested in conceiving for some time in the future, we can actually consider longer term options such as an IUD, an implant in the arm, an injection. These are things that can also prevent endometriosis from recurring after a procedure or help with symptoms before procedure, but they should be something that are a little bit longer term option. Some other medications, there are ones called GnRH analogs, and those create a temporary and reversible almost menopausal states where the menstrual cycle does not occur in the normal fashion, and therefore that will suppress much of the pain and the symptoms of endometriosis. A couple other meds there. One is a synthetic male hormone, which really does the same thing. And then the other one is an aromatase inhibitor. So that's one that works locally at the level of the ovaries and will suppress menstruation as well, and therefore also cut back on some of these side effects. So when we talk about fertility concerns with endometriosis, the selection of the treatment, selection of the evaluation really depends on the patient. So this is where it's going to be really important for you to come in, have an individual consultation for us to discuss what are the next steps and what are the next steps for you based on medical factors such as your age, any other fertility factor concerns, is there enough sperm, are the tubes open? How bad are your symptoms? How many symptoms are you having from endometriosis? Obviously we're going to talk a lot about what your preference is when we talk about surgery versus treatments, and we'll talk about the treatments, but the success rates of the treatments obviously come into play. Insurance coverage and cost is important, and any risks of any of these procedures are important. So that's something that we'll talk about as well. But really the main thing I want to emphasize here is that it's really an independent treatment plan, and it's something that's helpful for you to just sit down and go over with your doctor. So I will go over an overview, but then in terms of specifics, I'll answer some questions, but a consultation can be really helpful for you to get this information in detail. So as I said, one of the main treatments that we use is a super ovulation with intrauterine insemination. So I'm going to briefly talk about that. Often this process, basically, I like to say it's kind of like a numbers game, and it involves getting more eggs and sperm together. So let me tell you how we do that. So typically we'll give you an oral medication. You're going to take that for 5 days at the beginning of the cycle, and that's going to help you grow 1 to 3 eggs most often. And then at the time that you are going to release those eggs or ovulate them, we will plan to do an intrauterine insemination, meaning that we're going to take a sample of sperm, wash it, concentrate it, process it, take a tiny little catheter and put it right in through the cervix and be able to put the sperm right in the middle of the uterus, so that more of the sperm are able to get out into the fallopian tubes. Because when you have intercourse, you lose many of these sperm here at the level of the cervix and the vagina. So this is a way to bypass that and get the best sperm out to the tubes, and then try to get more than 1 egg for numerous reasons. If there's inflammation, if there is an anatomical defect, maybe we're able to bypass that by getting more eggs or having them come from both ovaries. And again, that's something that we would talk about, but that will increase the chances of success just by getting more folks in proximity. By folks, I mean gametes and eggs and sperm. So another option that we consider, again, depending on that personalized treatment plan, is in vitro fertilization. And so that may be if IUI doesn't work, if the woman's older, if the tubes are blocked, lots of reasons. And so that's something that we would consider individually. But if it is something that that you would decide to do, let me just give you kind of a brief overview of that as well. So, typically the brain will tell the ovaries to grow 1 egg every month, and that egg will be ovulated. IVF is a process where we actually give injectable hormones, such as this one. I don't know if you can see that. Injectable hormones that will allow the ovaries to grow multiple eggs at the same time. And so these injections usually are 7 to 14 days of injectable medications, but it's basically, we're using the exact same hormone that your brain uses to tell your ovaries to grow that 1 egg, but now we can grow a bunch of them and try to keep them all growing together. And so after about 2 weeks of these medications, then the ovary goes from this state to look like this, because these are likely mature eggs within these follicles. Here's the time when those eggs are retrieved. And then they are taken to the IVF lab, where here they're going to be cleaned off, they're fertilized, they're grown in culture about to this 5 or 6 day mark, at which point they're put back in the uterus. And so again, if that's the route that your treatment chooses, then we will talk about all of that in great detail at your visits. Good news is that in general with endometriosis, once you are pregnant, it doesn't really cause any complications. It actually gets better. So there's something about the hormonal environment of pregnancy that actually improves endometriosis and will lead to less symptoms. And obviously, if you're not menstruating regularly, that's going to reduce a lot of those other symptoms as well.